Welcome, everyone, to our monthly webinar. So excited to have you all with us today. We've got a tremendous panel that will be talking to us about how to prevent respiratory infections in schools through great indoor air quality. We are partnered with the National School Boards Association. The Go Green Initiative is very proud to bring you these monthly webinars. And if you stick around till the end, you'll have a chance to earn Magna Award points by taking a quick survey that couldn't be easier. I'm going to turn it over to the host of our panel today in just a moment, but I would like to mention that this is a Zoom webinar and not a Zoom meeting. And so if you have any questions, at the bottom of your screen, there's a Q&A button that you can push and ask questions at any point. We'll take those at the end of the webinar. Thank you again for joining us, and thank you to Erik Malmstrom, the CEO of SafeTraces, a good friend of the Go Green Initiative and a subject matter expert par excellence in indoor air quality, and has done some amazing things in several school districts. And I'm going to let him go ahead and introduce his panel. Thank you all for joining us.
Great. Thank you so much, Jill. Thank you so much to the Go Green Initiative and to the NSBA for the opportunity to speak to you all today. I am Erik Malmstrom. I'm the CEO of SafeTraces, and very excited today to bring a really top-notch panel to discuss a timely and important topic, IAQ, to prevent respiratory infections. So I am going to flip over to our slides here and then introduce our panelists. So give me 1 second. All right. And I'm going to go into presentation mode. And here we go. So I'm very honored and pleased to introduce our panelists. First, please join me in welcoming Yvonne Bonnie Maldonado, MD, who is a professor and chief of the Division of Infectious Diseases in the Department of Pediatrics at Stanford Medicine, as well as the Senior Associate Dean at Stanford Medical School. She also directs Stanford's Global Child Health Program and serves as the Medical Director of Infection Prevention and Control at Lucile Packard Children's Hospital at Stanford. She has decades of experience in research, in practice, and also serving on a number of top advisory boards regarding infectious disease, vaccination, epidemiology, and also, importantly, has a real long-standing commitment to schools and to children. Was very actively involved in supporting and advising school districts during the pandemic. And she will be speaking today with a medical and clinical perspective on this topic. Additionally, we're very pleased and honored to have Lori Olson Arzaga, who is the Director of Environmental Services for Clark County School District, the 5th largest school district in the U.S., serving over 300,000 students across nearly 400 school facilities. Exclamation point. That is a big school district. She holds a Bachelor of Arts in Chemistry from Cal State Fullerton, has certifications in hazardous materials management and site assessment and remediation, various occupational safety and health administration trainings, and is a certified environmental manager in Nevada. And I would say Lori also has been a true national leader in proactive indoor air quality program development, management, and has a background in microbiology too. So in addition to her frontline experience, it really has deep subject matter expertise on this topic. And she's going to share her experience implementing IAQ and preventing respiratory infections in Clark County. So, and briefly on myself, I am the CEO of SafeTraces. For those who don't know, SafeTraces is a Bay Area, California-based biotech company that has a technology platform for predicting, detecting, and preventing airborne biological threats, including respiratory illnesses. We work extensively in support of school districts, as Jill mentioned, and also beyond my work at SafeTraces, I'm a board officer and treasurer for the Build America's School Infrastructure Coalition, or BASIC, which is a diverse national coalition united in advocacy for a robust and reliable federal role in modernizing U.S. public school buildings and grounds. And I'm honored that Jill is also in the BASIC coalition as well. So great lineup. And what we want to do here today on the webinar, we have 3 learning objectives. The first, which Bonnie will kick us off with, is describing how respiratory infections spread and how to effectively prevent them. Secondly, I will then present on describing practical, cost-effective strategies for preventing spread via facility operations. And then Lori is going to follow me, providing a kind of case study frontline perspective on doing some of the things that I'm going to be providing an overview on. And then finally, the last section is kind of the where's the beef section of how does this actually create return on investment for school districts, and both from a financial standpoint, but also in terms of health and performance outcomes for students and for teachers and staff within school facilities. So thanks so much. I am now going to turn it over to Bonnie to provide us the medical perspective.
Well, thank you so much, Erik, and thank you, Jill, and to all of your listeners today and viewers for your attention. This is a really important issue, and I'm really appreciative of the fact that we're discussing it right before or right at the very early onset of respiratory virus season. So as Erik mentioned, I am an infectious disease pediatrician and an epidemiologist, and also do a lot of work, boots on the ground, to try to keep these infections out of our families and communities. So I wanted to just give a high level, couple slides overview of what it is we're talking about and how we think about preventing some of these diseases. So I'm going to focus primarily on respiratory viruses, because as I said, this is respiratory virus season, and they are highly common, very hard to prevent, but there are some tricks of the trade that we've all learned over time. So this slide just is a very high-level cartoon representation of the respiratory tract. When we talk about respiratory infections, really from the neck up, we talk about that being the upper respiratory tract, and then basically from the neck down is the lower respiratory tract. So when you see on the left-hand side, you see that the sinuses are included in the respiratory tract. The ear otitis media are ear infections. Pharyngitis, or a sore throat or a throat infection, and laryngitis as well. Those are all upper respiratory tract infections. And on the bottom end of that picture, you see that we can have bronchitis, bronchiolitis, and pneumonia. Bronchitis and bronchiolitis are really infections of the airways themselves. So these can actually be direct invasion, or they can be inflammation triggered by infections. So you can actually there see more coughing or wheezing symptoms. Pneumonia is actually an infection of the tissue of the lung itself. It can involve the airways also, but the hallmark of pneumonia is that you see infection of the tissue, and that can actually be quite dangerous because it really interferes with the ability of the body to exchange oxygen in the lungs, which is where that happens, and then have that exported out to the rest of the body. So this is a critical issue, and pneumonia is a major cause of death in most of the world, and around the world, in children under 5 around the world. Pneumonia is a leading cause of death of children as well as people over 65. So it is quite serious. Now you can see that, again, I'm going to avoid the bacteria, which are major causes of disease in these areas. But here we can see that viruses can infect both the upper and lower respiratory tract. And you may or may not be familiar with some of these viruses here, but rhinoviruses and coronaviruses there at the top, those are common cold viruses. We see those come and go all year round. We generally have many, many dozens of types of these viruses, and they actually don't provide long-term immunity. So you can get them over and over again. And they tend to be just a nuisance infection. However, as we know, there are some famous coronaviruses that are not just nuisance viruses, and those include things like SARS, the original SARS virus, which was identified in the early 2000s. Middle Eastern respiratory virus or MERS, and more recently SARS-CoV-2 or COVID in disease. We also see things like influenza or parainfluenza. Now RSV or respiratory syncytial virus has been recognized not only in children, but is a major cause of hospitalization and death in old people over 65 and those with underlying conditions, and is the cause of 2% of all hospitalizations in children under 5 during respiratory season. So you see that these are all very important viruses, and they can, and many of these affect the lower as well as the upper respiratory tract. And this is just a small smattering. There are many, many more. Next slide, please. So when we talk about viral infection and transmission, I don't want to get too detailed here, but this is kind of the way we think about it at the very high level. When respiratory viruses basically are exactly that. They live in the respiratory tract. They can go from the top to the bottom of the tract, but generally they can start off in the nose and the throat. And so therefore they can actually, and I don't have one right now, I just have a little bit of a frog in my throat. Sorry. They can form droplets, aerosols, and fomites. Those are the 3 areas that we generally focus on. Now, a droplet is exactly what it sounds like. It's a very large, heavy drop that generally comes out when you're speaking, when you are singing, or coughing or sneezing. And these are large drops. They are heavy and they can fall to the ground very rapidly. So you can see here in this little picture, there's a person with some kind of infection, virus X there. And as the person is either singing, speaking, coughing, or sneezing, this other person is very close to them. Here, there can be less greater than a meter, but if you're very close up, you're going to get a fairly hefty dose of whatever that person has in their upper or lower respiratory tract. And those fall right to the ground. They're heavy. They don't stay in the air. But if you're close by, you can get it right. You can get that in your airway fairly quickly. And again, that is very close distance dependent. Now, on the other hand, aerosols are droplets that are very small. They are less than 5 microns or less than incredibly small. They're not actually even visible to the naked eye. And these are droplets that are so small, they can actually get into and out of the lower respiratory tract. And it's said there, if you see that junction of the lung with the airway tube where it says bronchial, at that point, most particles that are more than 5 microns large will not get in. So at that point, you're only going to see particles or viruses that are less than 5 microns getting down into the lower respiratory tract. That's prime territory for viruses and bacteria. But importantly, they can come also back up. So when you cough or sneeze, and you have one of these small viral particle infections, they can travel up into the airway and be expelled. Now, those very, very small particles, because they're so small, they act like dust motes. And if you've seen dust motes in the air, you see that they just float around and you wonder, how long does that dust mote actually stay up there? Well, the answer is some of them can stay up there for up to 2 hours that we are aware of. It may be that they can stay longer, but we have documented infections from people who have been in a room with, say, somebody with a infection with an aerosol virus, and I'll talk about it in a second, that have been infected 2 hours after the infected person has left the room. So we know that at least for 2 hours, these things can sit in the air and then be inhaled by susceptible individuals. And the example that I'm talking about, of course, for some of you already know this, is measles. Measles is an aerosol virus. That means it can exist in the large droplets, but it also can exist in the very small, less than 5 micron droplets. It can stay in the air once the person coughs or even breathes, and it can sit around in the air waiting for somebody to come by and inhale it and cause infection. So in hospital settings, for example, when we have a patient with measles or say chickenpox or tuberculosis, which are other aerosol diseases, generally if they're in the CT scanner, the MRI scanner, or any room, we actually seal that room up and wait until at least 6 hours has gone by before we terminally clean that room out, because we know that if you clean that room, there will still be particles sitting in the air if you don't wait at least 6 hours to get rid of them. Now, that leads to the third area, which is fomites. And we terminally clean, meaning we clean all the surfaces. Those little drops, whether they're the large droplets or the very small ones, can eventually at some point land on surfaces. And those are called fomites. Fomites are basically infectious particles that now sit on surfaces. And depending on the organism, they can last for seconds, minutes, or in some cases, hours or days. So, for example, we know that fomites of SARS-CoV-2 can in some cases last more than 24 hours. And so that's why we are very careful about decontaminating surfaces. Next slide, please. And so, again, this has an important practical consideration when we're looking a little more deep dive here. So clearly, what we talked about, we understand that the nature of the virus, the type of interaction that the infected individual has with others in the room is very important. So if you are within coughing or sneezing distance, those bigger droplets will definitely impact you. But if you also say shake hands with the person who's basically potentially been coughing into their hands or wiping their nose or mouth, we know that we can touch our faces quite a bit. We haven't done that so far on this webinar, but we know that people touch their faces quite a bit. And you can actually then shake hands with somebody and you might spread that organism that way, even if the person is, for example, wearing a mask, if you aren't careful with hand hygiene. Now, for people who are further away and not having contact or droplet interactions, if it's an aerosol, it can spread to that other person across the room. And that also depends on things like personal protection, as I mentioned, hand washing, but also ventilation. Ventilation is clearly important because that can the lack of proper ventilation can allow organisms to travel longer distances. Next slide, please. Now, and now that we have the basics here, let's talk a little bit about respiratory diseases. Now, I am not a magician. I don't have a magic ball, but I can tell you that I can predict that we're going to have a respiratory season this year. We are going to see flu, we're going to see COVID, and we are going to see RSV, among many others. And so that is almost as predictable as the sun coming up every morning. But the nature of the season, how bad it's going to be and which viruses are going to show up is not always as predictable. You can see here in this slide taken from the CDC that the lighter green peak shows that that was the 2022, 2023 flu season. Then you see 2023, 2024. And then 2024, 2025. And it looks like it was a blunted season, but in fact, it was a very severe season. So even though the numbers of combined diseases overall, these were all three combined together, flu, RSV, and COVID, we actually had a very severe flu season with more deaths in children, more hospitalizations than we had seen since 2017. So we generally don't know how bad the season's going to be, which virus is going to really take precedent. But we do have some helpful information from the Southern Hemisphere, which already had their flu season because their winter already ended. And it turns out that the flu vaccine was about 50% or so effective at preventing serious influenza infections. So we know that the vaccine is actually quite good this year at preventing infections, at least in the Southern Hemisphere. So the other thing you see here is that the season is very predictable in terms of a general season. So we know it is quote unquote winter season, but you see how broadly the winter season exists. So generally starts in October and it tends to end by March, but you can see there that even in April, there are some trailing cases and the season never it can sometimes trail on even beyond that, but generally we say October to March. So I think I have two more quick slides to go through, if I can have the next slide. So what are risk factors for children? We're talking about schools, and I work in a children's hospital, so that is our major concern at all times. Well, risk factors for children, one of the things that I studied over the years was how the immune system evolves in children to prevent respiratory and other viral infections. And we know that children's immune systems are evolving, especially in the first 2 years of life. But through 5 years of age, children have not been exposed. I mean, these are brand new clean slates. They haven't been exposed to a lot of the viruses and bacteria that all of us older individuals have. So they're going to be seeing things that their bodies have never seen before. Fortunately, they have largely have very robust immune systems, but they are still developing. So again, in the first 2 years of life, you aren't going to see as complete an immune response, although they do a very good job, as you will see later on in life. And in the early years, they are building up what we call memory cells. So when these children will see an infection a few years down the line, those memory cells will be reactivated. It's thought that they live for decades, and they can be reactivated, and then they will fight an infection that their body has seen before. So all of us who've been around kids know that kids get sick over and over again, and part of that is because we're bringing together a whole bunch of people who've never been infected with all of these organisms before. It's a perfect ground for transmitting everything that's in the community. Close contact and exposure, children are together a lot. They don't have a lot of boundaries. I know that we do a great job of trying to help them with that, but part of development is learning how to build those boundaries. And so they're together sharing all kinds of things that we probably don't want to know about, gum and, brushes and straws and cups, etc. And so it's a perfect setting for droplet spread. Fortunately, we don't see a lot of aerosol disease in this population, but if there are aerosol diseases like measles, you are going to see them spread in these areas. As adults, children touch their faces, and they probably touch them more often than adults do. They cough sometimes right into the open, although lately, traveling on planes, I've seen a lot of adults doing that too, unfortunately. And they have less consistent hand hygiene. Anatomical factors. One of the things that we really worry about in children is some of these viruses that affect and inflame the airways. And that's because our airways as adults are bigger, but children, and especially young children, have very narrow airways. So if you inflame those, it's very hard for them to breathe. And that causes wheezing, the wheezing and the coughing that you can see from some of these viruses, because their airways are just really tight. It's not just mucus, it's actually inflammation of the actual airway. And it's very hard to reverse that. In fact, there's no known way to really reverse that on a long-term basis other than to really just avoid that, or to do what we call supportive care. So providing humidifiers, etc. But you have to let that run its course, unfortunately. And then of course, as we talked about, these children have not been, they're fully susceptible to most organisms in their environment. And because viruses, especially the flu, evolves every year, adults may have partial immunity to the strain from the year before, but children, especially those under 9, may not have any immunity or may have very poor partial immunity. So they may be more likely to become infected. And so finally, I'd like to talk about the American Academy of Pediatrics recommendations. The American Academy has been recommending immunization schedules since the 1930s. So they are experts in this area. These are frontline providers. The AAP represents 67,000 pediatricians in the US. They recommend annual influenza vaccine for everybody 6 months of age and older, except for those people who have contraindications, and those could include things like adverse reactions to the vaccine. They recommend RSV immunizations for adults 65 and older with underlying conditions, and those 70 and older across the board. And for pregnant women to protect their babies from infection when the babies are born. There's also a monoclonal antibody against RSV that will protect young babies, newborn babies who have the highest risk for hospitalization from RSV. And they recommend COVID vaccination, especially for babies 6 to 23 months of age and anybody who wants to be protected. We talked a lot about behavioral and environmental. I won't go over these in depth because I know I'm going to hear a lot from my colleagues here, but we can teach. Children are very good at learning. So I remember my kids coming home, they're in their 30s now, but when they were little, they would tell me, we learned about hand hygiene. We learned to cough and sneeze into our sleeve. Staying home from if you're sick is critical. It is hard to keep a child home with a runny nose because they have them a lot, but if they're really sick with a fever, they should stay home. Limit exposure to crowded settings or those with respiratory illness, especially during respiratory virus season. Avoiding smoke exposure is critical. Please encourage breastfeeding when possible. And of course, ventilation and cleaning is absolutely essential in our school and congregate school environments. And so I'll stop there and hand it back off to Erik.
Great. Thank you so much, Bonnie. And I'm going to take the baton on that last bullet there on the ventilation side. So I'm going to try to work through this relatively quickly so we hear from Lori, because I think her perspective is incredibly valuable. But just to give you a framework to think about controls or ways of mitigating and preventing spread of infectious aerosols. The CDC, NIOSH, and the American Industrial Hygiene Association have something, they have this schematic here, the hierarchy of controls, which shows from top to bottom, starting with most effective and going to least effective, this inverted pyramid, which lays things out in elimination, substitution, engineering controls, administrative controls, and then personal protective equipment. I'm going to be focused most on the engineering controls piece of this, but just to walk you through these briefly. So on elimination, that's encouraging symptomatic or infected individuals to stay home or work remotely. We know that in schools, that isn't always happening, often because schools, aside from serving an educational purpose, are providing a childcare purpose. And so often sick kids are going into school. On the substitution side, this is not really applicable, or it's less applicable to infectious agents. The engineering controls are things like ventilation and improving them with something called equivalent clean airflow, which beyond just ventilation itself also includes filtration and disinfection. And then, below that on the pyramid are the administrative controls, which are screening protocols to identify symptomatic individuals, training employees on recognizing symptoms, and promoting hand hygiene and respiratory etiquette. Finally, the last part of the pyramid here is PPE, and that's stuff like masking. But we know as we go down the chain here, down the pyramid, there's more and more porousness in those controls. So you really want to be operating at the top of the pyramid as much as reasonably possible. So in terms of reference standards and guidelines, specifically for control of infectious aerosols, which is a subset of broader indoor air quality, I wanted to call out a couple things I think are important for people to be aware of. So in a world of normal operations, which is a bit of a subjective term in that it's how we're going to run the building normally, a couple of years ago, the CDC put out its updated guidance on health-based ventilation, where it put out a target of 5 equivalent air changes per hour, which is turning over the air within a classroom or an indoor space 5 times an hour through ventilation, filtration, and other mechanisms. And this is how they have recommended that buildings always be run. And I'd say it's especially important in higher occupancy areas within buildings. So that's one frame of reference. And then also we have a program with Underwriters Laboratory, our company SafeTraces, where you can basically do a performance verification of the building to see that it's hitting essentially that number on a regular basis. For extraordinary events like pandemics or respiratory season, and particularly bad respiratory seasons, ASHRAE, which is the American Society for Heating, Refrigeration, and Air Conditioning Engineers, which publishes building standards, 2 years ago also put out a new standard for the control of infectious aerosols called ASHRAE Standard 241. And this is the first consensus-based code enforceable standard that sets requirements for something called an infection risk management mode, IRMM, or what I call is the kind of infection control knob on the HVAC, where you would want to be running the system in these periods of elevated risk. And also this concept of equivalent clean airflow, or ECAI, which is a CFM per occupant or cubic foot of air per minute that is clean through ventilation, filtration, and disinfection. And this would, for school classrooms, that number is 40 CFM per occupant. And so you can either crank up the HVAC system, or if you're running that way already, then you're good to go. But also one of the other controls you have is reducing the occupancy within the space by going from your max occupancy to something less than that to support this 40 CFM per occupant number. For the non-facilities and non-engineer HVAC people on the webinar, just giving you brief visualization of these different types of engineering controls. So the first, I'm going to be working my way on left to right here and top to bottom. So ventilation includes both natural and mechanical ventilation. The natural is opening windows and letting in, quote, fresh air or outdoor air into a space. Not every building has the ability to do this, but when you do, you can open windows, and assuming that the outdoor air is not polluted or doesn't have other contaminants, this is a pretty low cost, low tech way to improve ventilation. Mechanical ventilation is taking outdoor air through an air handling unit and then often filtering it to come into the building and then distributing it within the spaces within the building through the supply air, where you can see that kind of air coming in through the top, getting pumped into a room, and then it goes out the return and you're filtering it. And that's the other way that HVAC systems are ventilating buildings. So that's one common method of controlling infectious aerosols. HVAC filtration is essentially the same thing as ventilation, except you're pushing the air through a filter, and that captures a lot of particles, and whether it's non-biological particles coming from the outdoor air, or it's biological particles like pathogens and infectious aerosols within the space. When you recirculate them, the filters, if the air is flowing correctly, can kind of remove them from circulation and protect people. Within the room, and I'd say this is very important because for infectious aerosols, the risk is really at the room level based on our understanding of the science and the data. The idea that infectious particles are traveling from one part of the building through the ducts to another part of the building and dumping out seems very unlikely. More common is there's a bunch of people in a room, one or a few of them are sick, and then they're spreading it to other people within the space. And so things like in-room air cleaners, which are your portable HEPA units or other either ground-based standalone units or ceiling-mounted units, are able to provide, I'd say, more effective control closer to the source, i.e. the people or the infected people. And so those have become, I'd say, much more popular over the past 5 years, particularly during the pandemic. And then finally, you have germicidal ultraviolet irradiation, which can come in the form of upper room, where you have 254 nanometer units that are installed that kind of beam the top of the room, and those can inactivate the pathogens so that they're no longer infectious. You also can put them in duct, and they can clean the recirculated air. And then finally, you have portable units similar to in-room air cleaners that can be on the ground or other places and also provide this benefit. So I'd say that this is where most of buildings are kind of focused. And I'd say often schools are largely in the ventilation and filtration category of things. And in some cases, supplementing with air cleaners and UV. In terms of what's appropriate for a given building, this really depends on your building system type. And so I'll follow up with Jill to provide these links in the notes. But there's some fantastic fact sheets that the U.S. Green Building Council and ASHRAE have provided for schools on being able to figure out, based on your current building design and the mechanical systems you have, what are the kind of options that you have from the things I just listed, what's appropriate given the starting point and baseline of your building. And so I'm not going to walk through this, but I think step one is figuring out what you've got already. Not all of the options are going to be viable or feasible in your building. And so you have to figure out, what have I got? And then from there, that kind of then determines which of the various controls are going to be appropriate for you. And then of course, there are other cost and energy, and other practical considerations on what makes sense for your building. I don't want to go through this slide in detail other than to say that in some respects, each building is a snowflake. It's unique. And figuring out what is the best way for it to achieve the CDC and ASHRAE guidelines really depends. And at one level, that's kind of annoying because it makes things complex and you can't really have a one size fits all in many cases. But in many cases, it's a good thing because then you can right size what's appropriate for a given school facility. And then thinking at the district level, what do you want to do? You have a lot of discretion to figure out what is the best thing. And each of those are going to have various infection control benefits, broader indoor air quality benefits, as well as cost, energy, practicality, operations and maintenance kind of considerations. But, the good thing is that you can figure out with the appropriate planning and the appropriate stakeholder engagement, you can figure out what is the best for your district and then kind of go from there. In terms of what I think are useful frameworks and tools for kind of tackling this exercise and process of figuring out what's appropriate for your school and for your district kind of portfolio, I would highly recommend ASHRAE Technical Committee 9.7's document that is the design guidance for implementing indoor air quality programs in schools. It gives you very practical frameworks regarding what are kind of the prioritization of different tasks, and it breaks things down into prerequisite tasks and then very high, and medium priority. The prerequisite tasks start with a verification assessment, figure out where you're at. And I'd say these ventilation verification assessments go beyond traditional facility conditions assessments, which I'd say are often kind of check the box and also priced below what you see here. I would just say on those FCAs that you're often getting what you're paying for. And so spending a little bit of more money up front to kind of really figure out what you have and how it's performing is really valuable, because that can then guide, where you need to make investments and where you're going to get the biggest bang for your buck. But then from that, you also need to figure out what's going to be the district strategy. And are you going to have the peanut butter approach of spreading the money around all the schools? Are you going to have a kind of needs-based approach where you're going to take the facilities that are the oldest and maybe have the most amount of problems and kind of prioritize there? Are you going to focus on certain student populations? You ultimately have to pick a strategy and approach, and then, of course, involve the right parties and stakeholders, which are not just facilities, but also school boards, administrators, parents, teachers, and make sure that it's an inclusive process. And then this also needs to get baked into master planning for not just facilities design, but also the operations and maintenance, or O&M side, which I just want to say is often neglected in budgeting and is also one of the things that is often cut first, which I think is incredibly damaging, because once the building is built, it often is there a very long time. If the average building in the US lasts 50 years and has a 50-year design life. And so you need to be ensuring that building is maintained for the long term. The risk factors for US school facilities. So I'll summarize this with our school facilities are in pretty bad shape. The American Society of Civil Engineers this year put out its report card for U.S. infrastructure, and school facilities is one category of infrastructure. We got a D+. We got a D+ in 2021, 4 years ago. Some of the issues are the average age of the main instructional buildings in U.S. school districts is 49 years. And when there's a 50-year design life for the building, so we're basically at the end of life. Less than 50% of all U.S. school buildings have undergone significant renovations or replacements since their original construction, and less than 33% have undergone improvements in the past 15 years. That's not good. 41% of school districts have needed new HVAC systems in over 50% of their schools as of 5 years ago. And nationally, we have an $85 billion annual funding gap in U.S. public schools to maintain a state of good repair. And there's new numbers that are about to come out in the next month, and that number has gone up. So we got some big issues, and we've been dealt a bad deck on the school facility side. One last point before I turn it over to Lori is when we actually do HVAC modernizations in U.S. public schools, I'd say that there's such a fixation on just, get the new equipment in, or if you're renovating, get the new best stuff. But then we're not really being smart and responsible about ensuring that the new stuff we're getting is actually performing correctly. And within California, Lawrence Berkeley National Labs did a study a few years ago that found that within California, 85% of recently installed HVAC systems in California K-12 classrooms did not provide adequate ventilation. That is just a staggering number. What was found was that field inspections had identified HVAC equipment, fan control, and filter maintenance problems in over 50% of the studied classrooms. Problems were improperly selected equipment, lack of commissioning, incorrect fan control, and maintenance issues are all associated with under ventilation. It recommended and concluded that better oversight on HVAC system installation and commissioning was needed to address this issue. And also periodic testing of ventilation is recommended to detect and correct ventilation problems. So I would say, just in closing, this is a big chunk of money that school districts are spending on their facilities. And school districts would be very well served to kind of put more scrutiny on this. And this is, again, not just the engineers and the facilities people. It really is an administrator and school board issue as well. So I am now going to turn it over to Lori to bring us home here on her experience at Clark County. Lori, you're on mute. Sorry.
Sorry about that. Thank you very much, Erik, Jill, and Bonnie for participating in this webinar with me and giving me the opportunity to speak. Yes, we are facing a challenge with unprecedented certainty and critical impacts to student and staff health outcomes. But over my over my 30 years of experience as an environmental scientist and a decade here at the fifth largest school district in the nation, I'm excited to share today with you evidence-based strategies that are transforming the way we protect the student health and optimize learning conditions. So next slide. You got the next slide for me, Erik? Oh, there it is. Okay. Give me a minute here. So why does IAQ matter? Yes, it's infectious disease prevention with proper ventilation, like Bonnie and Erik have mentioned. It also, attendance is vitally important. It's shown that when students are in the classroom, they perform better. And while attendance has many reasons why someone wouldn't come to school, definitely we want to optimize the environmental conditions, so it's not one of them. And then we saw the devastating effects of closing our schools. So learning continuity is a significant reason why we need to look at the environment so that we don't have to close our schools again. And in general, I want to tell you, though, it's important to understand the classroom air quality. And classroom in general do not have an air pollution problems when the systems are functioning properly. The challenge is oftentimes the need of the space will be changed, or they'll increase the number of occupants to the original design of that space to provide the proper ventilation. And then also occupants that introduce contaminants, like coming to school sick, or they'll add unapproved cleaners or just air fresheners into the space, which are asthma triggers. So there's a lot of common sources of indoor contaminants, but mostly they're coming for these reasons and not typically due to an air pollution problem that's coming from outdoors, unless you have things like wildfire or fires in the area. So next slide. So we do have expert guidelines from the CDC, ASHRAE, as Erik has mentioned. And but what we found out here at the Clark County School District is that we do get some guidance from the health district, the Southern Nevada Health District, but at that time it was a new area, and so we kind of were left on our own to come up with what to do about the situation we found ourselves in. I will say that there also needs to be some standards for some of the air quality parameters that I'll be talking about, particularly with CO2 and particulate matter when we monitor those. And those don't exist. And just like we developed water standards, I think that we need to have indoor air quality standards as well for some of those parameters. But the good news is that today's classrooms have been built to code. One of the first building codes was because they had an explosion of a natural gas at a school. And so building codes have been developed, and these older schools were maintained or built or designed to meet those standards back then. When your systems are maintained, when the HVAC and the water systems are properly maintained, optimal conditions are sustained. However, we do, as Erik has mentioned, that dollar figure, I'm not sure if he meant, we don't have dollar, when we build a new building, they don't build in the cost of maintaining it. And preventative maintenance is something else that needs to be added when we do receive funds for a building, so that we can maintain them over the life of the building and beyond. And then lastly, when we do properly maintain the environments directly, it does support student health and well-being and academic performance. Next slide. Give me a minute. So let's see, what are we on? Okay, there we go. So yes, when the systems filtration systems are changed. So in the next slide, I'll tell you that being in the largest school district, we have over 20,000 classrooms. So filter changes means 90,000 filters throughout the district that need to be changed. That's a large task to do. And then another performance essential is something that we've talked about several times, is ventilation monitoring and preventative maintenance. But the bottom line is a practical approach is you can't manage what you don't monitor. So today, what's great is the smart technology that's available. I'm an advocate for having a smart monitor in every classroom with the basic parameters like carbon dioxide, CO2, and particulate matter. You saw in Bonnie's slides that particulate matter less than 1 micron matters. So having a monitor that does the PM 2.5 along with 5 microns and 10 microns is very valuable to know. And of course, we have other parameters like VOCs, CO monitoring, or formaldehyde, and others, which are great as well, especially for the labs or art rooms or other specialty rooms, so that you know exactly what's going on in every classroom. To Erik's point about some of these upgrades, CO2 monitors can go into your ventilation system, but then they do the zone. So if you have a particular problem in a classroom, you're not going to identify it. And that's why I'm a big advocate for smart monitors in every classroom. And what I mean by smart is, I love the term IoT. The first time I saw that, it made me laugh, and it's because when you're able to see on a dashboard and have alerts sent to you, you can address the issue before maybe the occupant even knows what's happening, and it cuts down on as well. We'll talk about this a little bit in the next slide, but we have budget restraints, and having a dashboard help us prioritize the needs. Our technicians can get out there and address them. Remotely seeing what's going on first helps cut down labor hours as well. So next slide. I'll just summarize this real quickly since I see we're running out of time. Again, proper ventilation is key to what matters with prevention of infection and help creating a healthy space for the students. Particularly, you can use the CO2 measurements within from the monitor to determine the airflow and to optimize the airflow. And then the other thing I'd like to bring out, using SafeTraces, we have certified that it's a great way to do an assessment on your HVAC systems, because we've not only identified those areas that are meeting ASHRAE standards, and we also identified areas where our airflow was high. It was up in the 8 and 9 range almost. And that's an area of opportunity to look at for energy efficiency. But I will also comment that during those assessments, we did have great news. Over 95% of our older systems were performing above the 5 mark, air exchange mark, and it was simple fixes like broken ventilators, fresh air airflow ventilators. And so it was easily fixed. It didn't cost a lot of money to go and get all of the units being certified, is what I'm trying to say. Okay, so next slide, please. So we've kind of talked about this. I'll briefly just mention the assessment is where you want to start, and using and then deploying the smart monitors, and then educating stakeholders and maintaining and optimizing your systems using the data that you have gotten from your smart monitors is the framework that we use here now at the school district. And then real briefly, I'll mention funding is always hard to come by. I did install smart thermostats throughout all the portables, 2,000 portables here at the district, but that was using ESSER funds, and now that's gone away. I'm looking now working with MV Energy here to have a partnership where they'll help with the cost of installing some smart thermostats into the district. But things that don't cost money that you can do now to a comprehensive prevention strategy with respect to disease is, as best as possible, educate people to stay home when they are sick. And then using proper hygiene to prevent that contamination of the classroom. And then optimizing airflows, like we've talked so much. And then lastly, making sure the classrooms are cleaning on, using regular surface disinfectants that are approved and other products in the classroom as well. So the key takeaways, next slide, please. Lastly, like I've mentioned, properly maintain the classroom will provide optimum learning conditions. Smart monitors transform our ability to manage the air quality. Comprehensive strategies like ventilation, hygiene, cleaning. One of the things I didn't mention is air purification, I think, is the next step. It's evolving to where it's smart as well, where you can have air purifiers, whether they be HEPA or UV lights in the ceiling, can be turned on and off when the room is occupied or used. And that is our next generation of prevention. And with that, I'd love to connect and discuss, if we have any time, with what's been going on here at the district. And I'll give it back to Jill, I guess.
Thank you so much, Lori. Erik, did you want to wrap up things with that ROI piece? Yep.
I'll make this quick. There is a lot of lost school days due to respiratory infections. So nationally, that number is estimated at 40 to 50 million lost student school days per year in the US. That is an astounding number. And in terms of just the quick back of the envelope math in terms of what this costs districts, loss per pupil, average daily attendance funding, you multiply the 40 to 50 million by $50 per day, and you're in the billions. Substitute teacher coverage, another 1 to 1.5, additional cleaning, health staff, admin, another half, 500 million to $1 billion. And these are just direct costs. Then there's the cost of families getting sick from kids getting sick at school or daycare. So this is a real big cost to us all. And this doesn't even get into the negative impacts to learning, to teaching, to the performance of kids within school and teachers and staff. So I'd say that this is a really important area, not just as something we should be doing, but also from a financial impact standpoint. Getting a hold of this problem or wrangling this problem can be very impactful. So with that, I'm done. Over to you, Jill. Thanks so much.
Thank you, Erik. And we can go to the last couple of slides that I've got. I've got some QR codes for you all. Just really quickly before we answer some final questions. If you are trying to earn a Magna Award through the National School Boards Association, every webinar that you attend monthly, you can earn points for. So please grab a hold of that QR code and take the short survey, and you will get a certificate of completion automatically emailed to you. One more slide. We do this every month, folks. We're here every month with our webinar series on improving indoor air quality in schools. Next month, we are going to have some tribal leaders who have been working on indoor air quality issues in their communities and in their schools. They've got some best practices to share with us. We're very excited to have them next month for our November webinar. So please grab that QR code if you'd like to get ahead of the game and register for that. We do have one more open question from Todd Crawford that I'd like to read. It said, should we consider that residential schools or dormitory living at colleges will lead to greater infection transmission risk? Is there additional guidance that should be given to these institutions?
Yeah, so I'm happy to take the first crack at that. I think that the answer is yes. And some of the reference guidelines and standards that were mentioned, like ASHRAE 241 and the CDC, are applicable to those buildings as well. The ASHRAE 241 breaks buildings down into kind of space and occupancy types, and then within those buildings, kind of certain areas that are at higher risk, and it just puts out numbers on CFM per occupant, or cubic foot of clean air per minute that should be provided. So residential is really important because outside of work and school, then people go home, and when you're in communal congregate living, things can spread, and so it's very important those spaces are addressed as well.
Thank you, Erik. I want to thank our panelists. I've got one more question coming in, but for those of you who have to go, let me just say one quick thing. I want to thank Dr. Maldonado, Erik, the CEO of SafeTraces, and Lori with Clark County Schools in Nevada for joining us. You all are our all-star panel, and we couldn't be more proud to share your message with our audience. For those of you who are watching and think, boy, my board members or my superintendents or my facilities manager should see this. We are going to record this. We have recorded it. We're going to put it up on our YouTube playlist. And everyone who registered for this webinar will be receiving an email tomorrow with a link to that recorded webinar so you can share it as you like. One more question. Some schools are turning down donations of high quality air purifiers, presumably due to liability. Do any of the speakers have strategies for overcoming this resistance?
I'm happy to take it. I'm happy to let someone else, Bonnie or Lori, do you want me to go, or would you? Okay.
Go ahead.
I think that I'm speaking not only as someone working in this space, but as a parent. I have elementary school age kids, and parents and PTAs need to speak up and express their interests. I think that in many cases, school districts are being proactive, and in many other cases, they're not. And at the end of the day, they will respond when people tell them that they should be doing this, they want you to do this, and it reinforces the message that this is a priority. When school districts are rejecting resources, my question as a parent is why? Why would you not take something? And understanding the reason for that, because in general, if you can do something that's going to move the needle to create cleaner air and remove infectious aerosols, we should be doing that, especially in resource constrained environments, because often the response is, well, we don't have the money. So, I think that you just have to get involved and express viewpoints, because if that doesn't happen, then school, this can get buried amongst other competing priorities. But I would be interested to whoever asked that question to kind of talk offline about what the dynamic is. But we saw during the pandemic, a lot of school districts didn't use ESSER funding, and it went unused. And there are a lot of questions and media reporting regarding that. So, it kind of depends. But I think we should be doing everything we can to reinforce the message.
I'll just chime in a little bit here. So the district is twofold why they might not accept it. The district is in the business of education, and the Department of Environmental Services isn't. They know we're here, but they don't know much about what's going on with the air quality, so to speak, at that level. So that's one reason they might not accept it. And the other reason they might not accept it is because it's an equity thing. Like, they don't want schools who are giving these donations to receive it when others aren't. So that's one reason.
Great perspective. I mean, also sympathetic to the school district side. I mean, it's just hard when people are, a lot of people have become kind of armchair indoor air quality quarterbacks over the past few years. And I'm sure people like Lori and many others are having parents and others talk about MERV 13 versus MERV 11, where that probably never happened before. And I view that as a good thing, because it shows that people are more interested and engaged. But that also can be very hard when you're kind of planning at a district level to have lots of people coming and saying, well, why aren't you doing this or that? And so I think there's probably a right way to bring something like that to the district where it doesn't become unwieldy or unmanageable for them.
At this point, there are no more questions in the Q&A. Erik, thank you for putting this panel together, and thank you everyone for joining us. We're going to be here same place next month with our webinar. And as I mentioned, you'll all be getting an email tomorrow with information on how to register for that. Thank you all so much. Have a wonderful week and do something in your life to go green.
Thank you,
Thank
Jill.
you, Jill. Thanks, everyone.